Now it's time to welcome our speaker. Dr. Kimberly Huhmann earned her bachelor in medical degrees from the University of Nebraska. After completing her residency in obstetrics and gynecology at the Nebraska Medical Center, she then moved to Boston for a fellowship in pediatric and adolescent gynecology at Tufts Medical Center. Kim is the medical director of pediatric and adolescent gynecology with Norton Children's Gynecology, chief of gynecology, Norton Children's Hospital, and clinical faculty in obstetrics, gynecology, women's health, and pediatrics at the University of Louisville School of Medicine. Welcome, Kim.
Hi, thank you for that introduction, Jim. And thank you all for attending our session today. I was going to talk about some common pediatric gynecology issues and things that people tend to have questions about. So we'll be covering period problems and what to do with them. If throughout the presentation you have any questions, I think submitting them through the chat would be helpful. And we'll have time for questions at the end as well, where we can answer them verbally. But I'm excited to be here and let's get started. So for disclosures, I don't have anything to disclose. Things that we're going to learn today. By the end of the talk, you should be able to distinguish between normal and abnormal menstruation, discuss common menstrual problems, and then review treatment options for those. So we'll start by just covering what's normal and not quite normal first. So the pubertal progression begins somewhere between 8 and 13 years old. Typically there's a growth spurt, then pubic hair, breast development, and about 2 years after breast development, the period comes. At first, normal periods occur every 21 to 45 days. So being irregular is a normal thing the first couple of years. Bleeding should be 7 days or less, using 6 pads or 4 super tampons or less than a day. And if there's mild cramping, it should be well controlled with heat or ibuprofen. So that's kind of what's typical. Let's dive into the meat of the conversation and go through some of these common menstrual concerns. So through this talk, we'll work our way through this pie, first starting with irregular periods. So the most common reason to have irregular periods those first few years after menarche is because they're anovulatory and the HPO axis is immature, meaning that it's more of an estrogen dominant state and it's progesterone deficient because it's the ovulation of the egg that triggers the ovary to start making progesterone. And it's the withdrawal of progesterone if no pregnancy occurs that leads to a period. So with an estrogen dominant state, cycles tend to happen about every 21 to 45 days. For the first 3 years, this is pretty common. People tend to, or some adolescents will get to ovulatory periods more quickly than others. But by 3 years after the first period, 95% of people should be having ovulatory cycles. There is an inverse relationship with periods becoming ovulatory in relation to time of menarche, meaning if you have menarche at an earlier age, you tend to reach ovulatory periods faster. And if you have menarche at a later age, it might take longer for those periods to become ovulatory. PCOS tends to be a really common problem or concern, or I wonder if this is the reason why their periods are irregular. And so we'll dive a little bit more into that. So there's this criteria called Rotterdam criteria. Typically you have to meet 2 of the 3 options or 3 pieces of this in order to meet the criteria for PCOS. So hyperandrogenism, whether that's hirsutism on exam or severe acne on exam or serum evidence of hyperandrogenism through lab work, irregular periods, and polycystic ovaries on ultrasound. In the adolescent population, we don't use this ultrasound piece as part of the criteria. So it's just the first two, and having the first two can meet criteria for PCOS. We do tend to wait at least 3 years after menarche before we would diagnose PCOS, just because, like we talked about previously, it can take 3 years for periods to become ovulatory and more regular. And there's a lot of causes for this, and definitely a hereditary component. So if there's a strong family history of PCOS, then that should increase your suspicion in a patient that you're seeing that you're concerned about. A typical workup for irregular periods includes a TSH, prolactin, and FSH. You can consider adding androgens, testosterone, DHEAS, and 17-OHP if you have any concerns for hyperandrogenism, or if you're wanting to get more information about possible PCOS. Long-term management, you can just track periods and see if they start to regulate over time, and to better understand how regular and irregular they are. A lot of the teenagers nowadays have an app in their phone, so sometimes they can already very clearly tell you when their periods were. Other times they have a harder time being able to provide that history, and so giving them some time to track their periods and come back could be helpful. Other options are if they're going longer than 3 months without a period, that tends to be our line in the sand of when to treat versus not to treat. If they're getting periods irregularly, but it's happening more frequently than every 3 months, it is okay to keep track of those, and you don't necessarily need to treat if the family and patient prefer not to do anything. When it goes longer than 3 months, we worry about the lining of the uterus growing thicker than we'd want it to, and leading to an heavy and long period whenever it does come. So we do tend to recommend treating those in some manner. One option would be to use Provera in a cyclic manner. So 10 milligrams a day for 10 days. And you can repeat that every 3 months, and that tends to kickstart a period within 2 weeks of finishing that medicine. Downsides of that, it just takes a lot of tracking and logging and making sure when was my last period and when do I take this medicine. But the benefit is that if you have a spontaneous period, then you can recognize that and see it, and then restart the 3-month clock after that spontaneous period. Other options would be your typical birth control, either the combined options or progesterone only options. Any of them are reasonable places to start based on what the patient history allows and what their preference may be. Amenorrhea, or the lack of a period. There's 2 types. There's primary and secondary. Primary means they've never had a period, and secondary means they've had a period, but now it's been a long time since the last period. So for primary, they meet criteria for primary amenorrhea and should be get a workup if there's no period by 15, no secondary sex characteristics like breast development by the age of 13, or they had breast development start, it's been 3 years or more, and they still haven't gotten a period. For secondary amenorrhea, a workup should be started if they have not had a period in more than 6 months, and that's if they've had previously irregular periods. But if their prior periods were regular, you only need to go 3 months without a period before it would be a good idea to start doing a workup to investigate why. The workup for amenorrhea looks a lot like irregular periods. So getting an FSH, TSH, prolactin, considering androgens, obviously ruling out pregnancy. And then where primary amenorrhea varies from secondary amenorrhea is that you should really be getting an ultrasound. And the reason why is with primary amenorrhea, you don't know if they have all the anatomy to even have a period. So checking to make sure a uterus is present is helpful, and it will help with the differential diagnosis list as well. And then after getting that labs, you can just treat the underlying cause. And I think referring to us at this point would be helpful. I think if you can get the labs and potentially some imaging studies and then send them our way, that you, from a pediatric primary care standpoint, that's excellent. From a secondary amenorrhea, that you can kind of do similar treatments that were available for irregular periods. So doing the Provera withdrawal every 3 months would be reasonable, or using any of the combined or progesterone only hormonal options. The birth control choices would be other alternatives. And then switching gears and talking more about heavy periods. So what is considered too heavy? And it's saturating more than 6 pads in a day or using more than 4 super tampons in a day. And really it's the saturating piece of this. Often kids will change pads or change tampons more frequently just because that's when they have the moment at school to do so, and they don't want to overflow on their clothes. So I think it's important to understand if it seems like they're changing rather frequently, what's the reason why? Is it because everything's full and if they wait longer, then they're concerned that they're going to overflow? Or is it because this is my opportunity, or I do it for cleanliness? That those are helpful distinctions to make. Other things that they could say that could give you an indication that it might be too heavy if they're changing every 2 to 3 hours, passing clots greater than an inch in diameter, if they're flooding or overflowing onto pajamas or bed sheets at night, and it's not just because the pad shifted, it's because it's pretty full, or they have signs of anemia, lightheadedness, dizziness, or shortness of breath. Those would all be indicators that this period is probably on the heavy side. And what we worry about is if is there a bleeding disorder that we haven't diagnosed yet? Because about 20% of those with heavy periods have a bleeding disorder, and von Willebrand disease tends to be the most common inherited bleeding disorder, and it can be seen in up to 25% of those with having chronic heavy menstrual bleeding. So when do you screen for a bleeding disorder? If one or more of the following exist, then it would be reasonable to screen for a bleeding disorder. So periods are lasting more than 7 days with flooding or gushing or bleeding through a pad or tampon within a couple of hours. They have a history of anemia. There's a family history of a bleeding disorder, or if they have excessive bleeding after surgery or a dental procedure. Any one of those should alert you to maybe consider screening for a bleeding disorder. So basic workup for someone coming in reporting heavy periods would look at their vital signs, physical exam, looking for signs of anemia. And if you don't have any acute concerns for anemia or bleeding disorder, then getting your basic labs with CBC, ferritin, and TSH is very reasonable. You do more of an extensive workup if you're concerned for a bleeding disorder or anemia. And what that means is the basic plus coags and a von Willebrand panel. You can always consult hematology for co-management, and then additional testing such as platelet dysfunction or other bleeding disorders that they can check for. You can also consider a pelvic ultrasound just to check the lining, the thickness of the uterine lining. Maybe it's extra thick and that's the reason why they're having such heavy bleeding. And then, so what do we do to treat acute bleeding? So this is the patient that having a prolonged period, it doesn't seem like it's ending, or it's heavy and they're bleeding today and we need it to stop. The previous recommendations would probably be an OCP taper, but we've shifted more away from that, just because when you're doing an OCP taper, the amounts of estrogen that you're taking in have a lot of side effects. in terms of nausea and vomiting, and then you have to prescribe Zofran, additional medication. And then what do you do if the patient has a contraindication to estrogen? So switching and doing this Provera taper avoids some of those side effects. And it can also be used in patients if they had a contraindication to estrogen. And so what the taper entails is it's Provera 20 milligrams 3 times a day for 7 days, followed by 20 milligrams daily for 21 days. And then after that, you can either watch and see, or you could transition them to whatever long-term management they were wanting to start. An alternative option would be tranexamic acid, and then you can use up to 1,300 milligrams 3 times a day for 5 days based on the patient's weight. You can always consult with us or with hematology if you wanted to know what the best dose for your patient was, and we'd be happy to talk you through that. It is important to know this is an off-label use in adolescents under the age of 18. Long-term management, so treating the underlying cause of the bleeding if there is a bleeding disorder. You can use non-hormonal options. If you're not concerned for anemia, it just seems like the patient has slightly heavier periods, labs are all normal, you can do scheduled NSAIDs during the first 3 days of their period, and there can be some reduction in flow. Can also help with painful periods as well, so it kind of can hit both of those areas. Tranexamic acid is also another option that can be used during the time of the period, and it's not a daily medication outside of that. Then other options are the hormonal choices, typically the birth control options of the combined, and then the progesterone only choices. And so I was going to go through just a couple of scenarios. So this would be like a patient, we'll talk about the blue first, that you came in, reported heavy periods, and then had a basic workup. And the CBC showed mild anemia with a hemoglobin of 11, low ferritin at 15, and a normal thyroid. I think next step for this patient would just be like, what do we want to do long term? We have a mild anemia, starting iron, whether it's a multivitamin with iron or ferrous sulfate, and then what are these other options would you like to try with follow-up in 3 months to see how that's improved or how that's going in terms of managing that period and make adjustments based on that. In the orange, this patient has more of a moderate anemia, and the hemoglobin's 8, the ferritin's low, around 4, and a normal thyroid. The next steps with this patient is I would recommend adding on the extensive bleeding workup, getting coags and a von Willebrand panel. And really my line in the sand tends to be when the hemoglobin's below 10. So if I feel that is where I add on additional lab testing to look for a bleeding disorder, because it's more likely that one may exist. If they're actively bleeding, then using one of the acute management options with the addition of oral iron. If they're not actively bleeding, then choosing one of the more long-term management options. I would not recommend NSAIDs being the choice. I think we need to be using either tranexamic acid or one of the hormonal options to manage that period. Next is painful periods. So there's primary and secondary dysmenorrhea or painful periods. Primary is what we typically think of as just painful cramping during a period. It's due to the increased in prostaglandins. Teenagers tend to have more painful periods than adults. Treatment can be NSAIDs or use of hormones. You can use ibuprofen 600 to 800 milligrams every 8 hours, or use naproxen 250 to 500 every 12 hours. I recommend if they're going to use NSAIDs that they start at the moment their period starts or the moment they feel pain of their period coming through the first 2 to 3 days of their period in a scheduled manner. That tends to be when the period pain tends to be the worst. If that regimen of NSAIDs is not adequate, then the next step would be to look at hormonal treatment. For secondary dysmenorrhea, this means there's some kind of underlying cause present. So is there endometriosis? Is there a structural difference or an obstruction that's leading to more painful periods than we would expect? This becomes higher on the differential when you've potentially tried different treatment options, and thinking that this is more of a primary dysmenorrhea and you're not getting anywhere, you're not getting enough relief. Then you would think maybe is there something else going on. If you thought that I'll go back one more. If you think that there might be a structural difference or some kind of obstruction, or they come in shortly after menarche and it just sounds like these periods are absolutely terrible, it doesn't seem like your typical adolescent coming in with painful periods, it is reasonable to get an ultrasound to rule out any GYN pathology or obstructions. So that would be one thing that you could consider earlier on if you felt like it was necessary. So the different treatments, kind of similar treatments that we've been talking about, combined estrogen and progesterone options, the pills, the vaginal ring, and the patch. Using something that has an increased progesterone and decreased estrogen activity, like microgestin, could be helpful if the main concern is dysmenorrhea. Trying an extended cycle pill, which means that you get a period every 3 months instead of every month. And the Seasonique or Seasonal are the two types of pills that are built to be every 3 months. You can also consider continuous pill taking, and basically you skip that placebo pill week and you go straight into the next pill pack. The one thing to note is anytime you skip a period, you increase the risk of breakthrough bleeding. It does tend to improve with time, but it's something to talk about with the family so that they're just aware. What I will typically say is if we're choosing an extended cycle or continuous fashion and how we're taking the pills, I would say if you get breakthrough bleeding, pause the pills for 3 days, just have the period, and then restart where you left off. Over time, those episodes of breakthrough bleeding should spread apart. And give the family prolong the breakthrough or continuously. And then the patch, I would caution continuous use with the Xulane patch. The reason being is that the Xulane patch, the amount of estrogen that the body is seeing is probably closer to a 50 microgram estrogen pill, and it's just a little too high estrogen to do that on a continuous basis. The Torla patch, which is a newer patch, downside is that it sometimes isn't covered well by insurance. That patch is closer to a 30 microgram estrogen pill, and those we use on a continuous or extended cycle basis all the time. So that could likely be a safer option to use the patch in a prolonged fashion. Some progesterone only options, they're progesterone only pills. So norethindrone acetate or agestin or medroxyprogesterone can be used. Those two are not birth control. So I often will make sure that my adolescent patients are aware of that, as sexual activity may change in the course of their treatment. Micronor or norethindrone or drospirenone, which is also called Solin, are also progesterone-only pills, and those are birth control, so they can be used for both. I will say Micronor is not the best birth control, so if you have a patient that's sexually active on Micronor, I would have a conversation about maybe an alternative option that's more effective. Depo-Provera or the birth control shot is an option. The arm implant, the Nexplanon, or the progesterone-containing IUD are all additional options that can be great for treatment of painful periods. And then I think we're to our last common concern, which is mood concerns, PMS and PMDD. So the incidence for premenstrual symptoms is up to 75% in women that have regular cycles. So it's a lot. Having premenstrual syndrome or PMS is about 20 to 30%. The more severe form of that, PMDD, is 2 to 8%. And then those who have an underlying mood disorder, but maybe think that they have PMS or PMDD, is about 40%. So the timing's important. So PMS and PMDD should be recurrent and cyclic symptoms that end during that luteal, or that start and end during that time just before the period and then during the period. So it should start up to 5 days preceding the period starting through the first 2 to 3 days of each period. On average, it lasts about 6 days, and it should be pretty consistent cycle to cycle. And then this kind of a Venn diagram, because I think this sometimes can get confusing, so I think it's helpful to kind of see it broken up in this way. So a mood disorder is not cyclic. They have baseline symptoms all the time. It just and flares in their baseline symptoms, and it doesn't always seem to correlate with period. Someone can have a baseline mood disorder and also have PMS or PMDD, but then these flares of these symptoms and severity of the symptoms should be very clearly around the period, like we had previously discussed. So for PMS, it's this less severe form, one affective and one physical symptom present, and in this cyclic manner. PMDD is 5 or more serious or severe symptoms, and that can be a helpful way to kind of distinguish and break these up in your mind. So how do we treat PMS or PMDD? So for first line, the SRIs, like fluoxetine, could be helpful, sertraline. You can use it as a continuous. It could just be done in the luteal phase. It could be started on symptom onset. All of those are reasonable regimens in the treatment of PMS or PMDD. Other options would be to use oral contraceptives, where Yaz and Yasmin have been FDA approved in treatment of PMS and PMDD. I think this is helpful, one, because you just take a pill every day, and if you had heavy periods or painful periods or anything else that you wanted treatment for regarding the period, like we're hitting like everything with one medication. Regimens for this birth control pill could either just be a continuous fashion where you skip the period, the extended cycle giving the period every 3 months, or just doing a 4-day placebo to shorten that period window and amount of time that you're off hormones. And I do think that I get pretty good results with Yasmin and Yaz. So that tends to be if a patient comes in with symptoms that I'm concerned about, PMS or PMDD, this tends to be where I start in offering treatment. And so just kind of to recap, I kind of talked about different normal and abnormal periods and then some of these problems and what to do about them. And so I just want to kind of pull it together, and hopefully this slide can be just like a helpful like nugget of information. So for irregular periods and amenorrhea, getting TSH, prolactin, FSH, plus or minus androgens, plus or minus an ultrasound is a reasonable workup. And then based on the patient and some of these results, you can decide whether you're going to track the periods, use cyclic Provera or daily hormones. For heavy periods, starting with a basic workup of CBC, ferritin, and TSH, plus or minus coags and von Willebrand is a good place to start. And then deciding whether just to use NSAIDs or TXA during periods or daily hormones would be reasonable treatment options. For dysmenorrhea, NSAIDs or daily hormones would be great. And then for PMS and PMDD, the SRIs or daily hormones, and then Yaz and Yasmin are helpful to remember as a good place to start. I was going to go through just a few kind of pearls about different options, some of the things that we've kind of already touched on, but just kind of hitting home a little bit. We do recommend, if you're going to use a combined oral contraceptive pill, of using at least a 30 microgram estrogen pill and a monophasic pill. And so those are some examples of pills that meet that criteria. The reason we recommend a 30 microgram pill is that studies have shown that 30 micrograms is what is needed for bone health in an adolescent population, and using less than 30 or using the 20 microgram pills might not be adequately supporting bone health. I have people on lower than 30 micrograms if they've had side effects like nausea or headaches with a 30 microgram pill, and they do better on a 20. I think that's very reasonable. But I would start with a 30 and adjust down if they have side effects or reasons why they can't tolerate the 30. If they're going to be under that, under 30, then I would recommend making sure they have the right amount of calcium, vitamin D in their diet to help support that bone health. Yasmin and Yaz, as we discussed, FDA approved for PMS and PMDD. For continuous dosing, so skipping those placebo pills, or even for extended cycle where you're going every 3 months, have a period. If they have bleeding more than 2 days, stop the pills for 3 days, restart on the 4th day, and it should help that breakthrough bleeding stop more quickly. Again, a vaginal ring can be used cyclically or continuously. Use it continuously. I tend to just instruct them to change out the vaginal ring on the 1st of every month. For patch, I would caution using Xulane in a continuous fashion. And if a continuous patch is desired, the Torla patch would be a better choice. For progesterone-only options, we did touch on that Agesta and Provera are not contraceptives. That's important to remember. Micronorm are. Depo-Provera, one new thing that had recently come out, I think it was last fall, is that the MEC guidelines have changed and actually list Depo-Provera as a level 3 and maybe even sometimes a 4 for clotting disorders. Actually have it's sitting. So if there's a like sickle cell disease or increased risk for making blood clots or thrombophilia, I would double check the MEC criteria with that patient-specific information before jumping to Depo-Provera, because there have been some recent studies that show that maybe that could increase clot risk. The next one on is the arm implant. It's good for up to 5 years. FDA has only approved it for 3. Multiple studies show it's good for birth control, contraceptive benefit for up to 5. So we tend to just have that conversation. If the family or the patient feels uncomfortable going past 3 years, then we'll exchange it at the 3-year mark. Often people will like to keep it as long as possible and choose to exchange it if they have an increase in their breakthrough bleeding. And then the levonorgestrel IUDs, there's 3. The Skyla is good for 3 years. The Kylena is good for 5. And then the Mirena IUD is good for up to 8. But I think that's really most of what I had to cover today. I hope that that was helpful, and I'm open to have questions if anyone has any.
Yeah, it does look like we have some questions, Kim. So
Great.
we had one in the Q&A and then several that came in the chat, and we can handle all of them. So one question from the perspective of soaking pads and or tampons, how do you calculate that with the period underwear that's available?
Yeah, that's tough. And menstrual cups sometimes make it tough as well. I think it's using your best judgment and kind of trying to gauge with mom or the guardian. And if it seems like the periods are on the heavier side, start with a basic workup and add on if you need to.
So there's no calculation that's available to
Not
readily
really.
convert. Okay.
I would
Um,
say if the period underwear should last like 2 or 3 pairs of period underwear should last a full 24 hours. So if they're using more than that, then I think we that would definitely warrant a workup.
okay. Um, and then what type of patient would you recommend the vaginal ring to compared to the other methods that are available?
If they're tampon user, typically what I will say if you're not a tampon user, let's put it on hold until you become comfortable with tampons because they do have to place this ring in the vagina, leave it there for 3 weeks, and take it out every month. So they need to have some comfort with that. I will say I might have 1 or 2 patients on the vaginal ring. People don't tend to take that option very often, but it's really if they feel comfortable inserting and removing that device at home, I think it's a reasonable place to start.
And then do any of the implanted birth control options help with mood?
They've not been studied in that way. It's possible that the Nexplanon would, because there is some systemic hormone, so there could be a little bit of the blunting of the um, kind of like the up and down changes of the hormones through the course of the month. The IUD is so local that it really doesn't have a ton of systemic effect. So sometimes I'll have a patient that's on an IUD. And we add an additional pill medicine to it because they wanted adequate birth control without having to remember something on a regular basis, but then needed some help, additional help with mood. And so we kind of manage it that way.
So I would probably also throw into this implanted, from my perspective, the
Mhm.
injectable, so the depot medroxyprogesterone.
It is possible that Depo could help. It does have systemic ability. I think if someone has a lot of mood concerns, I wouldn't jump first to Depo. I'd be a little cautious about jumping to Depo because if they have a bad reaction and it actually makes their mood worse, you can't stop it or take it out. So if you wanted to start with a different option and they tolerated those fine, they just didn't adequately um, meet the needs for for the mood changes, and the Depo seemed like it was a good option. I think that would be fine. Um, but maybe as the first choice right out the gate, have the conversation with the family to say, hey, if we do this and it actually makes the mood worse, we have probably a 3 month plus wave to ride until this is starting to work itself out of the system. And I think it's just that's just patient-centered decision making, and they can decide what they like to do.
Yeah, in over, this is completely anecdotal, but in over 20 years of practicing, I'd found with the depot shot, I could roughly divide the symptomatology in thirds. So with bleeding, about a third got better, a third stayed the same, and a third got worse. And the same thing with mood. It was about a third got better, a third stayed the same, and a third got worse. And
Yeah.
it's maybe 40 and 25, and
Hmm.
you can, the numbers are slightly different from that, but the easiest way to explain it to patients was you're
The
you're
third.
yeah, you're cutting a pie into three pieces, and it just is a matter of which piece of pie you get.
Yeah. And I would say if someone's done well on a pill, either progesterone only or a combined pill, and mood wasn't a big issue, I think it's reasonable to try Depo, and the risk is probably low.
Um, so I don't see any other questions from our audience, but I had a couple things I wrote down. So
Yeah.
what are major red flags that if the pediatrician is seeing a young girl and she says this, what are the two or three things that you're like, oh my gosh, I need to see that girl next week?
From like a period management.
Hmm.
I think prolonged bleeding, prolonged heavy bleeding, that's extended past that, like 7, 10 days, especially if we're using like 4+ pads a day, because then we're working into like anemia. And giving us a call is helpful. I can normally give instruction or give some like recommendations of what to do right now, to get that to get controlled a little bit better, and then we'll get them into clinic and have them seen. Um, I think severe pelvic pain, I would get an ultrasound. And if there's anything on that ultrasound that, like a large cyst or concern for obstruction, that would be something that we need to see pretty urgently or pretty quickly.
And outside of those red flags, are there any things that you think are best managed with you and your group rather than in a primary office?
I think if there's irregular periods, more irregular than every like 1 or 2 months, especially if it's in any kind of like amenorrhea, secondary or primary amenorrhea, I think that those diagnoses and differentials and how you manage those patients can get kind of complex quickly. And so that those would be reasons to get them kind of started, but then transfer over to us. Um, any kind of like dysmenorrhea, painful periods doesn't seem to be responding well to kind of your typical birth control pills or different birth control options. And you're kind of like, I don't really know what to do next. Send them over. Bleeding disorder, heavy bleeding, would be best served here. We probably would help co-manage that with hematology. We actually should be opening up an MDC with hematology and gynecology this fall for heavy menstrual bleeding. And so we'll have a specific clinic where they can meet with both specialties on the same day. And so I think that that will be really convenient for those families. So if you're have a patient that you're concerned they have heavy periods and you're concerned that bleeding disorder might be present, um, sending over for our office or giving us a call and asking them to be seen or be evaluated to be seen in that heavy menstrual bleeding clinic, would be a really reasonable next step. Um, Other things for us, I mean, obviously, any kind of surgical question would be best managed in our office. And we can, I know some primary cares will place an Nexplanons, but if you ever have a concern or you question about any of the Nexplanons and placement, or want us to look at something because it just doesn't seem quite right, or over time it's hard to palpate and needs help, maybe getting it removed, we're always happy to help and assist in those cases as well.
And lastly, at least of my questions, if you have a girl that has maybe an eating disorder and that is the cause of their secondary amenorrhea,
Mhm.
um, is it best for you to help follow along with the treatment of the eating disorder so that you're ensuring that hormonally she's getting what she needs to grow and develop and bone health and all the things that our normal hormones are supposed to do?
Yes. Yes, we do follow. We also work in conjunction with Dr. Brittany Badal with Adolescent Medicine. Um, and it's been a really great partnership because she will kind of take on more of the eating disorder piece and help manage that with the patient and their family. And then they will come back and follow with us, and we'll basically be monitoring for additional progress as well as the spontaneous resumption of the period, which is the goal. And if we need to intervene earlier for kind of specific reasons, then hormonally we are able to do that.
Thank you.
Yeah, great
So,
question. Mhm.
thanks. So I don't think we have gotten any other questions in. So I want to thank everyone for joining us today.